Thank you for the opportunity to present. So this is a case of a open EVAR explant for a persistent type 2 or persistent endoleak. I have no disclosures. For HPI, this was a 69-year-old male, past medical history of CKD, Salzburg's cabbage. He had a AAA Salzburg's repair with recurrent endoleaks, and he had received multiple endoleak intervention at the outside hospital. He presented to our institution with the enlarging aneurysm sac to 10 centimeters and with still persistent endoleak. And specifically in regards to his aortic intervention history, in 2018 he had an EVAR with bimodular gore excluder, but persistent type 1A endoleak at completion, and he received proximal cuff and 4 endo anchors. And in 2019 he had a right hypocoiling and limb extension for a type 1B endoleak. 2020, he had an intervention for type 2 endoleak with either coil or glue. We don't have the op report for that, and he had another one in 2021. And this is the video for his CTA when he presented at NYU. And it's going a little fast, so just to slow it down as we come down. He had really only one good renal to the left. His right renal was atretic. And you can see the lots of coil in the sac, around 10 centimeter sac, and extension in the right limb. And this is a coronal picture for his large sacs, as well as prior endograft. So options at this point, we were really planning for open repair, as we didn't think a continued endovascular management was high yield for this gentleman. We really wanted to get higher up to above the renal, so we were planning for a retroperitoneal exposure. However, the other approach could be a transabdominal exposure. Since this was for endoleak management, we planned for a partial endograft explant, but the other options are complete explant versus a sacotomy with or without external reinforcement and just leave the endograft in. The clamp, we were planning for a suprarenal, as I mentioned, but the other options, supraceliac or infrarenal, or just no clamping and just enter the sac. The reconstruction was aortal by iliac, but the other options are tube or aortal by femoral with a buttress of the distal stump. Or continue endo management, which we didn't think it was high yield, or expectant management, which we didn't think it was appropriate because he was only 68 or 69 and was otherwise in reasonable good health. So for the description, we admitted him, we got him a stress test, he passed, and he was deemed an adequate candidate for open surgery. And we did the open partial stent graft explant and aneurysm repair via the retroperitoneal approach in October 2021 under general epidural and epidural and central angiotube cell saver, and we specifically asked for wire cutters. We positioned our clamp suprarenally. However, we didn't clamp, but we entered the sac. We didn't really see active overt bleeding. However, we did see a couple of small lumbar back bleedings, and these were suture ligated. We didn't really dissect out the right iliac, one for because he had extensive scarring over there. Another reason was it was rather difficult, so we just controlled the right common iliac origin. We reconstructed the aorta with a 22/11 bifurcated hemoshield graft, and these are his intake and outputs. And this is his position. We made our incision from the 9th intercostal space, partially removed the 10th rib, and extends the incision to the semilunar 9. And we hugged the retrorenal space. And this is the material that we scooped out after entering the sac. As you can see, there's multiple coils and the thrombus burden. We didn't really see overt purulence or signs of infection. And you can see the partially removed stent graft, what used to be gore excluder, and partially removed the limbs. And this is a picture of the reconstruction. So post-op, he was extubated and he was admitted to SICU. His creatinine began to uptrend since post-op day 1. However, thankfully that plateaued. And post-op day 7, he was advanced to regular diet. His AKI improved slowly, and he was discharged on post-op day 8. And he's doing well, still very well 1 year post-op, and his most recent creatinine is 1.2. And this is his duplex at 10 months. As you can see, a patent aorta iliac reconstruction. And this is just a paper by a collaboration of couples of institutions, and their take-home message was that after explantation of 32 EVAR, above 90% was for endoleak. Their operative mortality was 6.3%, and in elective cases, it was 3.8%. However, about a third of them had major complications. So their message was that these could be done safely. However, patient selection was important, and you need a system designed to take care of these patients post-op. So for discussion, the author mentioned that the median time to explantation was 3.8 years, highlighting the need for long-term imaging after EVAR. The extent of endograft excision often depends on pre-existing device seal, presence of suprarenal fixation, as well as underlying graft infection. The techniques for removal of suprarenal stent, that some of the adjuncts that they mentioned was using a wire cutter, large syringe to collapse the endograft, or unscrewing the endo anchor with Kelly, which we thought about doing but did not do. And each subsequent intervention and adjuncts complicates the possible ultimate explant, except for maybe type 2 endoleak coiling. But in conclusion, we believe it's critically important to evaluate patient for open surgery from the get-go. Thank you.